All right, welcome to this high-yield explainer on BLS Resuscitation, designed specifically for your EMT exam. We are going to cover exactly what you need to know to nail the questions in this absolutely critical chapter. So let's get right into it.
So here's our game plan. We're going to walk through the entire decision-making process for resuscitation. We'll kick things off with how to even recognize a cardiac arrest, then jump into high-quality CPR and using the AED, and we'll finish up with those really tough calls you're going to have to make out in the field. Think of this as your blueprint for the exam. Okay, picture this. You arrive on scene, you find an unresponsive patient. Every single thing you do from this point forward is something you could be tested on, so let's make sure we get it right. It all starts with one single critical question.
First things first, before you do anything else, you have to establish that they are truly unresponsive. So get down, tap them on the shoulder, and shout, "Hey, are you okay?" If you get nothing back, that's it. It's time to kickstart your cardiac arrest protocol. Now, this right here is all about efficiency. On your exam and for real out in the field, every second counts. Why? Because every single second without oxygen is damaging brain cells. So while your eyes are scanning the chest for any sign of breathing, your fingers should already be on the side of the neck, finding that carotid artery.
Okay, here's a number you absolutely have to burn into your brain. 10 seconds. That's a classic exam point. You get a maximum of 10 seconds to find that pulse. If you're not sure, if you're kind of feeling for something, just start compressions. A pulse you have to hunt for isn't doing the brain any good anyway.
Listen up, because this is a huge test trap. A patient who is gasping, like a fish out of water, that is not breathing. Those are called agonal gasps, and it's basically a reflex from a brain that is starving for oxygen. So for your test, agonal gasps means no breathing. You start CPR immediately.
All right, let's build on that and talk about the chain of survival. You can think of this as the framework for literally everything we do in resuscitation. And the exam loves to test the order of these links because each one is a step that has to happen for a successful outcome. So here they are, the 6 critical links. It all starts with somebody recognizing there's an emergency and calling 911. Right after that comes immediate CPR, which manually pushes oxygenated blood around. Next up, rapid defibrillation to try and shock a chaotic heart back into a normal rhythm. Then we show up, providing more advanced care and getting them to the hospital. And the chain keeps going at the hospital and all the way through the patient's long-term recovery. You've got to know these 6 links, and you've got to know them in order. Okay, this next part, you have to know this for your exam. I can pretty much guarantee these numbers are going to pop up. They define what high-quality CPR is, and they have a direct impact on whether a patient survives. You've heard it a million times. Push hard and push fast. We're talking a rate of 100 to 120 compressions per minute. Now that's the sweet spot. It's fast enough to build up pressure in the arteries, but it's not so fast that the heart doesn't have a chance to refill with blood between pumps. And yeah, the beat of staying alive really works. It's not just a cliche. Okay, what about depth? Well, for an adult, you need to compress the chest at least 2 inches, but no more than 2.4 inches. You need that depth to physically squeeze the heart between the breastbone and the spine. But just as important is allowing for full chest recoil. That upward movement creates a vacuum that pulls blood back into the heart, getting it ready for the next squeeze. Think about it like this. Every single time you pause compressions, blood flow to the brain and the heart just plummets to 0. It takes several compressions just to build that pressure back up again. So the huge takeaway here is to keep those pauses under 10 seconds. And whatever you do, do not lean on the chest. That prevents the heart from refilling. Now, here's a term you might see on newer exams, the chest compression fraction. It sounds complicated, but it's really simple. It's just the percentage of time during the whole cardiac arrest that somebody is actually pushing on the chest. The best EM systems shoot for over 80%, because more time on the chest means more blood to the brain. Simple as that. All right, let's switch gears and talk about special populations. Your exam will absolutely 100% test you on the key differences between resuscitating adults and kids. They're not just tiny adults, their bodies are different, and the reason they go into cardiac arrest is usually totally different. Okay, this table right here, this is your cheat sheet. Let's break it down. Notice the pulse check spot. For an infant, it's brachial, in the arm, because their necks are too short and chubby. Now look at the depth, about 1/3 the depth of the chest for both infants and children. But the biggest difference, the one you've got to remember, is that 2 rescuer ratio. For any pediatric patient, infant or child, 2 rescuers switch to a 15:2 ratio.
We're giving them more breaths. So why is the approach so different? This slide gets to the heart of it. Adults usually have a sudden electrical problem with their heart, like VFib, but kids, their hearts are usually healthy. They go into arrest because they stop breathing first, and then their body slowly runs out of oxygen. It's this lack of oxygen, hypoxia, that makes the heart slow down and eventually stop. And that's exactly why we push for more breaths with that 15-to-2 ratio. We're treating the root cause of the problem. All right, let's talk about the AED. Defibrillation is the link in the chain that can be a real game changer, giving the patient the absolute best chance of survival from a shockable rhythm. So let's make sure we've mastered how to use it, especially in those tricky situations the exam might throw at you. The exam loves to throw curveballs, right? Well, here are the 3 big ones you need to be ready for with the AED. If you see a pacemaker, that little hard lump under the skin, just place the pad at least 1 inch away from it. If the patient is wet, you gotta pull them out of the water and give their chest a quick wipe down. And if they've got a medication patch where a pad needs to go, take it off with a gloved hand and wipe the area clean. You're gonna see this question, or something just like it, for sure. That hard lump under the skin, that's a pacemaker or maybe an implanted defibrillator. So what do? It's simple. You just apply the pads in the normal positions, but you make sure that the pad is at least 1 inch away from that device. That's it. Okay, last section. And this one is just as important as knowing how to start CPR. It's knowing when to stop or when not to start at all. This is crucial, both for your exam and for your ethical practice in the field. So when do you hold off? It really boils down to 3 things. 1, if the scene is unsafe for you, don't become a second victim. 2, if there are obvious signs of irreversible death, like rigor mortis, stiffness, or dependent lividity, that purplish pooling of blood. At that point, resuscitation efforts are pointless. And 3, of course, if there is a valid do not resuscitate order. And once you've started, when can you legally stop? Well, there's a great mnemonic for that. STOP. You stop when the patient starts breathing and has a pulse, when care is transferred to another provider of equal or higher training, when you are physically out of strength and just can't continue, or when a physician tells you to stop. You've got to know this one. All right, let's wrap up with one final scenario to really get you thinking. You did it. Your patient has a pulse, what we call return of spontaneous circulation, or ROSC. But they're barely breathing. What's your very next move? Here's the key takeaway. You have to breathe for them. If their breathing is inadequate, they're just going to become hypoxic and go right back into cardiac arrest. So you grab a bag mask device and you support their ventilations. Never, ever forget to manage that airway, even after you get the heart beating again.